We shall now go on to our next dynamic speaker, Dr. Shushmita Kaushik, who's a professor of ophthalmology and senior consultant glaucoma services at PGI Chandigarh, and a very dynamic national figure, and has contributed enormously to the glaucoma in our country and international standing. And she's going to be telling us about exciting new developments that could change the future of glaucoma surgery. On to you, doctor.
Good evening, and thank you, Dr. Chitra, for having me on this exciting webinar. So, for me, the horizon of glaucoma surgery is primarily reorganization of indications. And I don't think there is a debate between MIGS and trabeculectomy, because I don't think MIGS will replace trabeculectomy, because there are aging populations around the world. There are progressing glaucomas. There are advanced glaucomas who come to us who will need low IOPs in the low teens, and trabeculectomy is going to hold the answer. So will it bring in a change in the paradigm? Most likely, yes. Early glaucomas usually are treated with pharmacotherapy, moderate glaucomas in 3 to 4 drops, and now we are going to consider surgery, but we are going to avoid doing trabeculectomy, and we are going to consider minimally invasive surgery. So this is really the snapshot of what we have. We have the outflow stents, the iTrack and Hydrus. We just heard one talk on that. Dr. Craig touched upon the iTrack and Omni for viscocanalostomy, in which you could click, and there are little aliquots of visco that are injected. And of course, you could strip it by a Cahuck dual blade, or even cheaply by a bent angle needle goniectomy or a bang. But I don't think MIGS is on the horizon. I think MIGS has arrived. And the thoughts for the future, conversely for me, is many more patients now are being referred for a trabeculectomy. And we absolutely still need a trabeculectomy in the future. And for a glaucoma specialist of the future, we need to learn trabeculectomy and understand the follow-up. It does not mean you cannot and should not also embrace MIGS. The future lies in providing the appropriate choice. It's individualized and it's based upon what each patient needs. So my wish list for a future of treatment would be slow release drug delivery systems for medications, rather than people putting drops, where the ocular surface toxicity would be minimized. The development of an ideal glaucoma surgery, as Paul Palmer keeps saying, the 10-10-10, 10 minutes, 10 millimeters of mercury lasting 10 years, and that's still on the horizon. Quick visual recovery and less sight-threatening complications. And finally, the RGC neuroprotection or regeneration of those which have gone, which is again on the horizon, a stem cell or gene therapy. So what's really on the horizon is Durysta, and I'm talking about India, because it's a 10 microgram in a rod-shaped biodegradable polymer with a 200 micron diameter. If it's FDA approved only for a single injection. And there are 2 trials, the Artemis 1 and 2, which have looked at, and phase 3 trials have 3 injections at day 1, week 16 and week 32. And the IOP assist at week 52, which means a year after the last implantation, was lower than timolol. So that's where we stand. It's not huge, but it's something. And the other thing on the horizon, which is not FDA approved as yet, it's still in phase 2, is iDose. And that's a biocompatible titanium implant, and that's impregnated with travoprost. So the other thing that we are waiting for in India, it's been approved in Europe, but FDA hasn't approved it as yet, is the PRESERFLO. Now this is SIBS. This is an exciting new material which is so biocompatible that there's no extrusions or expulsions. It's just 8.5 millimeters, 0.35 millimeter diameter, and a 70 micron lumen. There are 2 anchoring wings, position 4.5 millimeters posterior. There is decreased risk for post-op episcleral scarring, and early results are promising. So there's one that has come out with 3-year outcomes in a prospective pilot of 23 patients, where at 3 year it was down at 10 with a mean of AGMs from 2.5 to 1. And I could find a FDA exemption trial in children, so that caught my eye. Jamie Brand did that, 12 eyes of 12 children. They range from 15 months to 14 years, and the pressures were down from IOP of 22 to an IOP by 45% to about 11 at 1 year. And 7 of these children did not require medication as yet. So these are early things yet, but it's very easy to put in. It just takes about 10 minutes, and that's something to look forward to. The next thing on the horizon is for glaucoma drainage implants, and we're looking forward to these implants in India to augment the AGV and the bar welt that we have. There is an Ahmed Clear path which is valveless, but it's preloaded with a ripcord. So that's something which could be very exciting, because I know Aurolab is developing a 3O Supra Mid, and we're still looking for a multi-filament nylon, and this ripcord will already be preloaded in it. So you just need to put it in, and you take out the conjunctiva, take out the ripcord and implant it under the conjunctiva. And there are two sizes available, the 250 and 350 millimeter square. So the minute it's going to be introduced in India, we're all going to be happy to use it and see what happens. And the other thing which is very common in Southeast Asia now and very popular in Australasia and Oceania as well is a Paul glaucoma implant. And we like it because it's called the PGI. It's 342 millimeter square with a thinner lumen, a 0.127 lumen compared to the AGV and the RD, which is 0.3. And apparently this has given good results at 1 year as well. The other thing that's exciting is drug-eluting GDDs. This is something which I would look forward to, because it would prevent fibrosis and high blebs, which are bugbear, especially for AGV. So the two things that have been impregnated are mitomycin C and Plaxitaxel. Plaxitaxel actually has been coated with cardiac stents, and it's helped them in not reblocking and not having to re-stent the heart cardiac stent. So that's where the idea has come from. And it's experimental, yes, but paclitaxel coated GDDs should be something that we could all look forward to. And they've also been attached to slow release MMC delivery systems, so that it's a slow release of antimetabolite. Coming to the future, again, regenerative medicine. Stem cells have the potential to stop the progression of disease, and they replace tissue in the eye that has degenerated. And the other thing is regeneration of adult retinal axons. There's enhancement of neural activity combined with rapamycin, and these regenerate and re-innovate the brain. So that's been demonstrated in mice, and the next is going to be the primate model, and we're going to look at whether in vivo actually this works. So to summarize, I think the future of glaucoma surgery is all about choices and making good choices depending upon the patient who's in front of you. There's no dogma as to this surgery is better than that. The whole spectrum is amenable to some surgery or the other, depending on what you're comfortable with and what you can do. What is important is to recognize which would be the most appropriate for the best outcome for the patient who is sitting in front of us. Thank you very much for the opportunity again.
That was again a superb talk, Dr. Shushmita. We thoroughly enjoyed it. But just a brief at what we could achieve, could there be any improvement in understanding of the CSF pressure, or could there be anything about obstructive sleep apnea, or could there be anything about this 24-hour ambulatory BP monitoring? Like, would we learn something more in those directions?
Yes, I mean, there's fair amount of evidence that it's translaminar pressure that's important more than transcorneal, which is what we monitor. The problem with that is there's no way that we can raise the CSF pressure. So even if we understand it, I don't see, at least as of now, any way of raising the CSF pressure and reducing the translaminar pressure. So the only thing that we can do is lower intraocular pressure to reduce that. And as regarding the BP, again, the diastolic ocular perfusion pressure, the diastolic minus IOP, which is less than 55, is detrimental. But the problem is, if the diastolic pressure is less, again, there's no way to improve it or increase it. So the only thing that we have in our hands right now is a lowering IOP. But it's good that we are understanding this as well, and it helps to lower it further. And I think even in normal tension glaucoma, by lowering pressure, what we are doing is just increasing the diastolic ocular perfusion pressure rather than anything else, and improving perfusion to the optic nerve head.
Thank you. Thank you so much for that clarity.